from the American Academy of Pediatrics.
For the first time ever, the American Academy of Pediatrics has released guidelines on when and how children should be treated with opioids.
I think that what parents want to do when they talk to their pediatricians is ask lots of questions. And the first question that they should ask is, what's the expected amount of pain that my child will have from this injury, this surgery, and how long is that pain expected to last?
Welcome to Healthy Children, the podcast for parents from the American Academy of Pediatrics. I'm Dr. Edith Bracho Sanchez. I am a pediatrician and a mama figuring it out. This is a judgment-free space where all questions are good questions, and the answers will hopefully be even better. Let's get started. Today, we're talking opioids because, as I mentioned, we have clear and specific guidance from the Academy at long last. And the doctor who wrote the guidelines is here. Dr. Scott Hadland is the Chief of Adolescent and Young Adult Medicine at Mass General Hospital for Children and an Associate Professor at Harvard Medical School. He's also board certified in adolescent medicine, addiction medicine, and pediatrics. Scott, welcome.
Thanks so much for having me today.
I'm so glad that you're here to break this down for us. And perhaps the place to start, Scott, is with the obvious thing that comes to mind. Because when I think of opioids as a physician and a mom, the first thing that comes to mind is the risk of addiction. But you talk in these guidelines about all the things that you and the team of authors had to think about, such as adequate pain relief when children are recovering from surgery, for example. So let's get right into it. Tell us about all the things that you guys were weighing as you wrote these guidelines.
Right. At the heart of these guidelines, we wanted to make sure that children and teenagers were having their pain treated effectively and safely. And as you mentioned, I think we've had a bit of an overcorrection in the field of pediatrics, right? We know that opioids are effective at treating pain, and they have been a mainstay of medical practice for centuries, really, if not millennia. And what happened during the 2000s is as we watched opioid addiction and opioid overdose rates rise, physicians started to catch on, including pediatricians, and dramatically cut back on the number of opioids they were prescribing. And that, in many cases, might have been appropriate, right? We definitely want to reduce inappropriate and excessive opioid prescribing, but it also means that some children who might have needed their pain treated didn't get that treatment because a pediatrician might have been nervous about using an opioid. And so these guidelines are really here to sort of correct for that and to help encourage pediatricians to use opioids when it's appropriate and to do so in a way that's safe.
Scott, another thing that I found very interesting as I read these guidelines is that you and your team were also weighing the inequities, the historical inequities when it comes to addressing pain. Tell us about the things you were weighing.
This was really central to our guideline. We know based on many studies that youth of color, even when they experience the same pain, the same intensity of pain, the same types of pain related to the same procedures or injuries or illnesses, that they are less likely than other kids to receive effective pain treatment. And so we really wanted to make sure that this guideline was focusing on addressing these historic health inequities when it comes to pain treatment and making sure that all children receive safe and effective opioid prescribing when needed, but just pain treatment writ large when needed.
Who else, Scott, were you trying to not leave behind in these guidelines?
There were two other groups that we thought a lot about. The first one is children with disabilities, in particular, children who may not be able to verbalize the pain that they're experiencing or who may have experienced pain so much in their lives that people don't treat their pain like they would, say, a first-time pain episode. And we want to make sure that those children also receive effective pain treatment. We also worried a lot about teenagers who may have a history of a substance use disorder, in whom pediatricians might not feel comfortable prescribing an opioid because they're worried about the problems that that teen might have with an opioid. But these guidelines are really set up in such a way that we believe pediatricians can prescribe opioids carefully, thoughtfully, with close parental oversight, and with close follow-up by the pediatrician in a way that reduces that risk and makes sure that everybody has effective pain treatment when it's needed.
Yeah, so important, Scott. And, I have to tell you, in my practice, when I'm recommending pain medication, to be honest, it's usually for acetaminophen or ibuprofen for kids who had a minor injury, or maybe they're having headaches or abdominal pain. In my experience, the need for pain medication tends to be short-lived. We address the root cause, and that's sort of it. I don't usually prescribe opioids, Scott. But there are situations where some children may very well need an opioid. Talk us through what those situations or reasons may be.
Well, that's exactly it. The vast majority of pain that we address in the practice of pediatrics really does not need an opioid. And so we certainly talk about that in the guidelines. And in fact, one of the key conclusions from this guideline is that opioids should never be used alone. In fact, they should always be used alongside other medications like the ones that you mentioned, acetaminophen, ibuprofen, or other non-steroidal anti-inflammatory drugs. And then also non-medications as well, right? We know that heat or cold or stretching or physical therapy or a number of other modalities can really help to address pain. And it's really critical that we maximize these other approaches before then using an opioid, or using an opioid at the same time as those if the pain is expected to be severe. We don't actually make a specific recommendation about which types of pain should receive opioids, which procedures or which injuries should receive opioids. We actually leave that up to other professional societies that have statements about particular surgeries and particular procedures. But we want pediatricians, particularly those in outpatient settings, which is who we're speaking to in this guideline, to recognize that when a child is in severe acute pain, that an opioid is okay to use if it's needed to address that pain.
Yeah. So if I'm a mom, which I am, and my child were to have a procedure or a condition that required pain management, let's say an opioid in combination with some of these other medications, acetaminophen or ibuprofen, what should I expect? How should things go when I go to the doctor, Scott?
What we really want pediatricians to do is to partner with families and have a conversation about opioids. And one thing I think that many pediatricians can do is actually reassure families that the risk of addiction is actually relatively low. On an individual basis, studies have demonstrated that the rates of opioid addiction after a young person receives an opioid are often less than 1% in many studies. So that means that most patients by far who receive an opioid are not going to experience any addiction or risk of overdose from it. But of course, we want to make sure that we minimize the risk for that less than 1%, right? So we want pediatricians to be talking to families and thinking about ways to mitigate that risk, right? So some things that are in the guidelines include making sure that pediatricians talk to parents about what are the signs of an opioid overdose and how do you intervene in an opioid overdose. In fact, one of the headline conclusions from this guideline is that we concluded every prescription for an opioid that a pediatrician writes should be accompanied by a prescription for naloxone, which is the opioid overdose reversal agent that can save a life within seconds. And this isn't just for the child that the opioid's been prescribed to, but there might be other younger children in the home or somebody else in the house that can get into the medication. And so it's really important to make sure that this life-saving medication is on hand.
Yeah. Talk to us also about what the guidelines say about safe storage and the disposal of opioids once we are done with whatever treatment was prescribed.
Right. Those are critical steps that we also want pediatricians to talk to their patients and families about. So we want pediatricians to be telling parents to keep medications locked up in a lockbox or a locked cabinet. And ideally, parents are themselves administering the medication to the child or teenagers so that they have a real sense of how many pills are in the bottle, what time that medication is going in, and how much the child or the teenager is taking. And then when there's leftover medication at the end, we want pediatricians to have had a conversation with parents about how to get rid of that medication. And, in some clinics and health systems, there might actually be disposal boxes. We actually are very lucky to have a drop box at my clinic where parents can drop off excess unused medications. Those can be difficult for many practices to have because there's actually a lot of Drug Enforcement Administration regulations or DEA regulations around those. And so pediatricians can also partner with parents on where else in the community they can go to dispose of medications. Often they can be disposed of at a pharmacy or at a police station. And worst case scenario, many of these medications actually can simply be flushed down the toilet, according to the Food and Drug Administration. And so that's another way to get rid of medications, albeit with some environmental concerns, but certainly helps address the safety concern.
And Scott, if we are getting a prescription for a short duration, a short course of a specific medication, we kind of shouldn't be having that much medication left over. Is that right? There should be a bit of a gut check that if you have a lot of medication around the house, perhaps you were prescribed too much? I don't know. How would you word that? How would you explain that?
Well, that's exactly right. But the goal here is to adequately treat pain for as long as that pain is around, but not to have leftover pills after that, right? Because those leftover pills are known to have contributed to teens using opioids for non-medical reasons and potentially contributing to addiction in some teens. This has been documented in the past. And so one of the central recommendations that our subcommittee had was to make sure that pediatricians were using the lowest effective dose needed of an opioid to control a young person's pain for the shortest amount of time necessary. And the guideline actually says, really, most prescriptions should be 5 days or fewer. It actually turns out, in many cases, you can go even lower to 2 or 3 days. My own personal practice is that I tend to give enough until the next time that I can follow up with the patient. And so if it's Friday and a patient is in pain, I'll make sure they have enough medication to get through the weekend, but then we'll be touching base with them early on Monday to find out how their pain is doing. And so I'm not giving them extra pills beyond that, but I'm also checking in just in case they do need more.
Yeah, so important. And I think such important context for parents. Now, Scott, just to take a step back, I don't think we really talked about how these guidelines came to be. So how did it work? Give us sort of a look into how you and your team put this together.
This has long been a priority of the American Academy of Pediatrics. And in fact, two doctors in particular, Dr. Rayford Brown and Dr. Rita Agarwal, for several years had been really working hard to make sure that the American Academy of Pediatrics was focused on this issue. They are anesthesiologists working on the front lines who had really recognized that many kids' pain was going untreated or undertreated because of the swings that they had seen in opioid prescribing. We brought together a subcommittee that had a range of experts. And so I led the committee along with Dr. Agarwal. Her background is as an anesthesiologist. My background is as an addiction medicine physician. We also brought together experts with backgrounds in emergency medicine, in primary care, research implementation, so that we could make sure that guidelines were practical and could actually be applied in healthcare settings. A critical member of the subcommittee was a parent. We wanted to make sure that parents and families were represented at each part of our work. And so we had joining us a woman named Beth who has 2 children who have experienced pain off and on for years and have lived the experience of having that pain gone untreated. And her experiences were so valuable to the work of the committee and helped guide so much of what we did. Just a whole range of folks that came together to make sure that this guideline was effective. And of course, surgeons were at the table too.
Yeah, you can't forget the surgeons. But so interesting, Scott, how this comes to be, really. Now, hopefully, everyone at home has a pediatrician who has read through the new guidelines, who is thinking very thoughtfully about how long pain needs to be treated and what else can be done to address pain and following up and having all the discussions that we talked about. But, Scott, if those things are not happening, say our pediatrician perhaps hasn't read your guidelines, how can we as parents advocate for our family?
I will not be offended if every pediatrician listening has not yet read the guidelines, but I do encourage folks to pick them up. And fortunately, there's a nice summary at the beginning that brings together the various recommendations. I think that what parents want to do when they talk to their pediatricians is ask lots of questions. And the first question that they should ask is, what's the expected amount of pain that my child will have from this injury, this surgery, and how long is that pain expected to last? And then what approaches should we take to that pain? And I think in many cases, as we've discussed, an opioid may not be needed at all. And so certainly most procedures, including really common ones, dental procedures, having somebody's tonsils or adenoids removed, these often need no opioids at all. In fact, the standard of care is not to prescribe an opioid at the time of those procedures. But I do think it's important for parents to just sort of press their pediatrician on what if this pain gets worse? What's the next step? Because we really want to make sure that pain is treated, and we want to make sure that children don't experience undue and undertreated pain, because we know that's associated with distress and with poor psychosocial functioning. We're trying to avoid that.
Scott, I'm thinking as you're talking, my child had a minor procedure and I don't think I asked those questions. So let's say them one more time is, what is the expected level of pain? How long is that pain expected to last? And what if the pain is getting worse? I think those answers are so revealing and will really guide the plan that you make with your pediatrician, right?
That's exactly it. And again, not every procedure or episode of pain is going to need an opioid, but parents should know what to do, who to call, and how to go about getting pain addressed, rather than a child living unnecessarily with undertreated pain.
Absolutely. And lastly, Scott, you've been a guest on the show before. You know that we like to end with what we call a parenting prescription. So what is one thing you want all parents to remember when it comes to pain management in their kids?
I really want parents to understand that opioids, when they're used properly, are safe and effective, that they treat pain, and the vast majority of times are not associated with risk of addiction or overdose. And it's important for us as pediatricians to help mitigate that risk, right? To follow families closely, to prescribe only what's needed and appropriate, to reduce the risk that a child or a teenager is going to have a problem with an opioid. So that's on us. So I would just encourage parents to understand that when your child is in really severe pain, it's not bad to get an opioid. In fact, that might be exactly what they need to be comfortable for a couple of days. And that's okay. And that is in and of itself likely not associated with major risk.
Let's all work together to address pain and do so safely. Thank you so much, Dr. Scott Hadland, for joining us today.
Thanks for having me.
And thank you at home for joining us. If you like the Healthy Children podcast, please subscribe on your favorite podcast app and help us spread the word. Follow Healthy Children on Instagram, Facebook, Threads, and YouTube at Healthy Children AAP, and be sure to visit healthychildren.org, the parenting website of the American Academy of Pediatrics. Healthy Children is a production of the American Academy of Pediatrics. Our creative team includes
Laura Alessio,
Catherine Beard,
Garrett Brown,
Zach Christman,
Ann Johnsos,
Kathy Jewell,
Doug Nagel,
Jackie Ortega,
Susan Stevens Martin,
Mary Claire Walsh,
Hannah Weston.
And our theme music was composed by Doug Nagel. We'll be back next week. I'm Dr. Edith Bradshaw Sanchez. Thanks for listening.